In this lesson, I'm going to explain the mechanisms of labor and how they occur and your role in assisting this patient through this for a successful delivery. All right, so the mechanisms of labor are also known as the cardinal movements I have up here. So what this means, these are the movements that the fetus does to find its way out of the uterus. So first, the fetus has to be engaged, okay? So this means the head is in the pelvis. It is engaged in there, and it's not going to move back up. So this can occur up to a few weeks before delivery, and it's also known as a term called lightning or dropping. So this just means that the fetus head has come down, the baby's lower and closer to the exit. And hopefully, because of this, we've had descent because we're down, and hopefully we have flexion occurring, which, remember, this is chin to chest. It's just much easier for the fetus to kind of pave its way out if the chin is to the chest instead of extended. And then our descent is going to be spoken in terms of that station that the fetus is in. So are we at zero station, which would be at those ischial spines of the pelvis? So this is our zero station. Or are we +1, +2, +3, or -1, -2, -3? And then next we have our internal rotation. So the internal rotation is going to be rotating itself around to extend itself out. After our internal rotation occurs, we have extension. The fetus will extend its neck, so it's not going to be chin to chest anymore at this point. It's going to now extend its head out to to get itself pulled out of the pelvis bones. The face is going to be aligned with the maternal rectum here when it extends itself. And so then we have this movement here. Our extension is going to end with the head being delivered, and then it's going to rotate. We're going to have external rotation, and that's going to happen so that it can realign its body. And then it's going to have expulsion, which is when it will just be expelled out. So let's look at this image. We have here the head's engaged. So we're on the cervix, that we now have complete dilation. We're at 10 centimeters. And so with here, we've already had our descent happen. We're in the pelvis. We're fully dilated. Then we're going to have next the presentation of the head. So with this, we have the fetus. Internal rotations occurred. It was chin to chest, you can see, and then it extends its head. We have external rotation. So here, see how we're lined up with the maternal rectum. Then we're going to have that external rotation. We're trying to realign. And then expulsion, where the delivery of the fetus occurs. All right, so other pieces of our mechanisms of labor are going to be, is it true labor or is it false labor? So let's compare these. With true labor, there's contractions occurring, and these contractions are going to be strong. They're going to get stronger. They're going to be regular, so we can time them. So strong and regular. There are cervical change happening. So we have the dilation occurring of the cervix, and we have effacement. And then with our true labor, nothing will stop the contractions. Nothing's going to stop the dilation and effacement from occurring. Where our false labor, you have contractions, but they don't get stronger. They aren't regular, and they're just going to kind of fizzle out and stop. They don't get stronger. So with this, because of all that, we have no cervical change here. So with these are false, or also known as our Braxton-Hicks contractions. There'll be no cervical change, and they will stop. So if the patient rests, they stop. If she hydrates, it could stop them. And even walking around, They fizzle out. So walking with true labor is going to make those contractions stronger, and they're going to get closer together and be even more regular. So if a patient with false labor walks, that will not occur. Now let's look at the other items that occur prior to labor. So we mentioned that lightning, which is that fetus dropping. It's the other way to describe or term for it. So with this, the fetus is lower. So her bladder here, we're going to have an increased need to void because of the pressure on the bladder. And lungs, she's going to be able to breathe better, which is fantastic because the fetus is off of those lungs. Vaginal discharge. So this is increased. There's just some mucus that is coming out, and that is okay. There is brown or blood tinged, just some spotting, also a normal thing. And this is because there's a cervical plug. So in our uterus, and our baby's in here, and our cervix is here, there's a plug in there. And that plug is just made of mucus, discharge tissue. So as the cervix starts to soften and dilate, that tissue is going to come out. You no doubt, if you are a labor and delivery nurse, will have a patient show up to the unit with her mucus plug in a Tupperware container because they think this comes out and they're in labor. They are not. It just means that our body's getting ready. She's getting closer. So not a big deal, but it does come out. Some women, the plug comes out all at one time. Other women, they might just notice some discharge as they wipe. All right, our cervix. So the cervix starts to ripen or soften, and that's why this happens, the loss of the plug. There's also an energy burst in hormones. So something called nesting happens where they think they need to clean and organize the entire house because of this energy burst. They're getting their body's saying, hey, we got to get ready for this baby. And then because of this, we can have some weight loss. That's because with the hormones, there's fluid shifts. And all fine and normal at the end of pregnancy to have a little bit of weight loss. All right, so a rupture of membrane. So another little part of our labor process. So this can occur in several different ways and different times. Our PPROM, this is a patient that has a premature rupture of membranes prior to 37 weeks. So it's a preterm, because we're prior to 37 weeks, premature rupture. Because our ROM member is rupture of membranes. Okay, so preterm, premature rupture of membranes. So prior to 37 weeks, these patients that are a huge risk for infection. Anybody that ruptures is at risk for infection because we've lost that barrier. That amniotic sac was our barrier from keeping those bugs and bacteria and germs out. But now that it's gone, they're at risk. These women, because they've ruptured early, their labor is going to take longer. So they're at an even more increased risk of infection. PROM. So this just means premature rupture of membranes. And the reason why these patients get labeled as this is that they rupture before they're in labor. So their water breaks and they're not in labor. They're not contracting. So these patients also big risk for infection because their labor is going to be longer because we got to get it started for them. So this is the patient that happens at term. So that would be our beyond 37 weeks. So 37 plus weeks. Our SROM just means spontaneous rupture of membranes, the patient's full term. This is a patient that ruptures and is in labor. And then AROM. So this is an artificial rupture of membrane. So this is done by the physician and usually with a tool is going to pop that bag of amniotic fluid. Our management for this patient might involve rupturing the membranes, which remember that was the AROM. So if the physician does it, it's AROM. When it occurs, remember, it's going to get rid of that buffer of the amniotic fluid. So that head is able to drop down onto the cervix and cause contractions to happen and just strengthen those contractions because the barrier is gone. And then nitrazine. So nitrazine is a test that's done to see if a patient has ruptured her membrane. So this is your patient that's at home. She calls the unit or comes up and says she thinks she's ruptured her membranes. The nitrazine is a little vaginal swab that's done, and it is going, the strip is going to turn blue, and that equals rupture of membranes. It measures the pH of the fluid that's in the vagina. So if it doesn't turn blue, then it's urine. But if it turns blue, then it's the amniotic fluid, and that's because of the pH that it's measuring, and the amniotic fluid is more alkaline. Our education. So the patient's going to need to be educated on true versus false labor, or else you're going to have every patient coming in the second she feels contractions. So she needs to be able to time them. They need to be regular. They need to be getting stronger. Obviously, she's not going to know the whole piece about the cervical change and dilation. A physician or nurse would be checking that, but she can certainly know if she's having regular, stronger contractions that aren't stopping with rest or hydration. And then she needs to know when to call the doctor. So usually for this, we want the patient to call, obviously, if she's ruptured membranes, because we need her to come in. And then also if she's having contractions that are 5 minutes apart or less, and then any bleeding, she needs to call the office for. Reproduction is going to be one of our concepts because it has occurred, and then comfort, because we want to provide this patient with comfort during labor. All right, let's look at our key points. So the cardinal movements are going to be engagement, descent, flexion. We have internal rotation, then our head's going to extend, restitution, and then external rotation. So the body's getting realigned and expulsion occurs. And then our true versus false. So do we have regular contractions? Is there cervical change happening? And do they go away or do they stay? And then ROM is our rupture of membranes. So SROM means we are at term, and rupture and are in labor. AROM means it's artificial, the physician has done it. Our PROM just means our premature rupture, and that is going to be the patient that's not in labor but ruptures. And our PPROM, which is our preterm premature rupture of membranes. And remember, all of these rupture membranes, the patient is at a risk for infection. Make sure you check out the resources attached to this lesson and look at each of those different movements, the cardinal movements. Now go out and be your best selves today. And as always, happy nursing.